and we will make a start. So a very warm welcome to everybody for our National Paediatric Diabetes Conference 2025. This is a hybrid event. I believe we've got about 400 delegates at home and maybe about 150 in the room. So when we ask questions throughout the day, please do use your microphone so viewers at home can hear what you're saying. So the focus of today's event is on reducing and tackling inequalities. My name's Dita Aswani. I'm here in place of the lovely Fiona Campbell, who was unable to travel today because of the disruptions on the train line due to the storms. But she is at home, I believe. I'm a consultant paediatrician working in Sheffield. I work in diabetes and complications of excess weight. I've been on the NPDA dataset and methodology group for about 10 years now, I think. I've kind of lost count. And it's been amazing to witness the collective power and influence and ability to change strategy that the hard data has given us. And the strength of the audit comes from every single unit and clinical team being committed to spending many hours collecting, submitting, cleansing data, and using it to drive quality improvement. I'm also National GIRF Clinical Advisor for the Children and Young Adults Diabetes Programme and halfway through the systems reviews at ICB level. And the purpose of these reviews is to understand the reasons behind unwarranted variation and the narrative behind that in order to focus our resources for better outcomes for children and young adults. These are data-driven reviews, and without the NPDA, it would not be possible. So to start today's meeting, I'd like to introduce Professor Justin Warner. He's the clinical lead of the NPDA. Justin's always been very mindful of the impact of data collection and audit collection on stretched teams and ensuring that the collection is very clear in its purpose and measured in such a way that the findings are reliable and interpretable.
Thank you, Dee. I've been doing this for 15 years now, and I don't know how much longer I'll be doing it, but it's always a great privilege to stand here, and I represent you. You're the people who do all the work. I nag you, or my team, the team in the RCP station nag you for data all the time, but it is important, and it has driven quality in children's diabetes over the years. I'm going to present to you today some update from the 23-24 reports. This is the latest one, which we published in March. I've been given permission, and I have to jump through a few hoops to get that permission to show you some slides from the 23-24 report. Please do not take photographs and put them on social media, otherwise my knuckles get wrapped. They'll be with you before you know it in the middle of March. I've used this title slide here for quite a number of years now, and every time I think, should I be changing this little girl here who's doing a finger prick, because it's getting a little bit outdated. But I keep it there because I think it's important to know where we've come from. We've moved mountains in the last few years in children's diabetes care, so I like to keep it there. Just before I show you some data, this is one of my privileged jobs every year, is to judge or help judge one of the judges for the front page of the audit report. And if you don't know, what we do is we ask any child to paint a picture, draw a picture about the experience of their clinic. And you'd be amazed, they're very, very positive, all of them. This year we had about 30 odd applications, so that was the biggest year ever. And they all have these sort of comments on them. I can still do what I want to. Diabetes is not going to stop me. This year's diabetes, it's tough. I'm tougher. So it's a pretty amazing thing that these children, despite the fact they have this disease, they manage it as best they can. And diabetes is not going to stop you doing anything If you notice in all these little pictures, there's little freestyle Libras, pumps, to see little tiny things, but they're minute in the greater picture of things, which I think is also a telling thing. So although they might be attached to all this modern technology, they're actually able to cope with it. So these are the numbers. When we talk about prevalence in the NPDA, we talk about the prevalence of children up to the age of 25 who are managed by you in a paediatric unit. Admittedly, the numbers dwindle quite quickly after about the age of 17, 18. But there are, in this audit year, there are just over 35,000 children with diabetes. Nearly 33,000 of those have type 1. Just over 1,300 have type 2, and the rest a mixture of other forms, MODIs, CF-related diabetes. So what's been happening to those numbers over the last few years is that there's been a steady increase in that prevalence, or the number of children that you have. So the green bar is the England and Wales data. There were few units that didn't submit in that year. That was the COVID year. But you can see this gradual increase across the years. And then the Wales data is the red line, which perhaps may have just plateaued in the last year. We'll wait and see what next year's shows. But over the last 5 years, there's been about an extra 5,000 children out there with diabetes. That represents, if you divide that by 173 centres, your centre on average would have gone up by about 30 patients over 5 years. And you've got to manage that and fit it into your existing resource. And I thought about, well, why are we seeing this increased numbers? Is it because we hung on to them longer at transition over the COVID period? But in fact, if you look at the data, it doesn't show that. It's the same numbers transitioning through. And the reason it's going up is because the incidence has gone up. And this is the instance which went up dramatically here at COVID, particularly amongst boys. There is some evidence it's starting to come down a bit. And in fact, this year, we're more or less back to the pre-COVID year. But of course, it's going to take a little bit of time for those children to work through the system. And you may find your numbers start coming down over the next few years. I don't know whether it will. We'll see what happens. But that would be my interpretation of that data. Why is there an increased incidence? We could be here for a whole conference discussing that. I don't know the answer, but there may be something about immunogenicity that's happened during the COVID years. So let's turn to the essentially children, young people. This is type 1 diabetes receiving individual healthcare checks. This was the COVID year. See, it's massive sudden drop off, which is not surprising. We couldn't go anywhere we wanted to go, but it's recovered. It's recovered incredibly well and continues to gradually improve all the time. HbA1c, as you might expect, is up there. Pretty much 100% of children having at least one HbA1c during the year. And the others are as depicted there. But that's a very promising graph. There is, of course, variability by PDU. So each of these lines represents a unit of 173 units. The red bars are Wales, the blue bars are England. So you can see there's quite a range from about 75% down here right up to those who are achieving 100%. Here's the national average line here, which is 92% completed, which is, I think that's pretty amazing to get up to those sort of values. Here's the HbA1c chart, which everyone loves to see every year. So this is median HbA1c by year for England and Wales, and this is the current national mean in 23-24, which is 60 millimoles per mole. It haven't quite reached the 50-something yet. Hopefully next year. But it does continuing to drop. Perhaps not quite the rate that it was. If you look at the black dotted line, that was the trajectory a few years ago with HbA1c median falling by about 1 millimole per year on average. This has plateaued, well not plateaued, but it's slowed down a bit, and we're now dropping at about half a millimole per mole per year. And in a way, it's not surprising because we had a long way. Back here, things were not very good, and a lot of processes were put in place, such as networks, peer reviews, best practice tariff, all these sort of things, which drove this down. And in the early days, there was low-hanging fruit, and we did lots of quality improvement. It's becoming a little bit harder, isn't it, to keep this down here. But there are other countries that do it, and I'll show you those in a minute. I said, well, maybe we'll have 50-something next year. Those of you who follow quarterly reports may look at this quarterly report from one centre out of the 173 and look at this value here and say, well, this is quarter one, and this is quarter two, and the median HbA1c is 58 now. Remember, this is the summer Q1 and Q2, where children tend to do slightly better. We haven't analysed the Q3 data yet, it's just come in. Plus, this is not yet validated, and we're clear in these quarterly reports that it hasn't been cleaned, it hasn't been processed anyway. It's a little bit of a grab to give you some incentive and to look at your own figures and to follow it longitudinally. But let's hope it is 58 or 59, somewhere down there, and we're still on the downward trend. I'll come back right at the end to show you something about quarterly reports in terms of ethnicity and deprivation. I show you this slide every year. This shows you the variation in average HbA1c in all the 173 units. So the black diamonds are Wales and the greeny, bluey diamonds are England. This is the average for the country. These are means now because these have been adjusted. You can't adjust the median statistically. These are means, so they're slightly harder than the median value. And what's been taken into account in this is ethnicity, deprivation, duration of diabetes, and gender, to try and put everyone on an even keel. It's not perfect. I understand it's a statistical regression model, and it's not perfect, but it takes away about 10% of the variability. But there's still 90% out there which we need to work on to have everyone along this line. That's I can't leave till I've got everyone on that line. I'll be here forever, I think. It is achievable though. So this is a paper that was published in The Lancet in November last year, and it includes NPDA data. So I act as a conduit into international collaboration in audit data with quite a number of registries around the world. It's a very powerful collaborative, and this is the latest paper, which has looked at over 100,000 children from around the world with through different centres and registries. So on the left here is the HbA1c data. We are that purple line there. That is the NPDA. And above us, the only two centres above us are Type 1 Diabetes Exchange, which is the USA, and this one, which is the Australia-New Zealand registry. Both those are not complete audits because they're based on centres rather than a complete national audit. We, of course, are a national audit. And who's this down here? Sweden, always Sweden. And I think if Fiona here, we should be, I think they were 50, this only goes up to 2023. I think they're down to about 51 or something now, is there? So it is possible to do it. On the right here, you've got pump usage and CGM usage. We are, the NPDA is this blue line here. So you can see we're pretty much bottom of the file in pump usage. I know this is 2022. We've moved on a little bit since then, but so will everyone else. And this is the CGM usage, and this is us here. So we certainly, in the past, I don't know whether it's still true now, but certainly in the past have been underusing these sort of technologies compared to a lot of other countries around the world. So this is a complicated slide, but I think it's a very important slide, and we've had a lot of debate about whether we kept this in the report or not. And I fought to keep it in, and I'm very grateful to our statistical team who put this together, because I think it's very important. But I'm going to go through it a little bit slowly, so hopefully you'll understand it like me. So this is about technology usage and outcome, and it's the last 3 years. We've chosen 3 years, because that's how long HCL's really been out on the marketplace. As you go from left to right, there's increasing use of more advanced technologies. You start over here on the left, injections only, injections plus FASH, injections plus CGM, pump plus FASH, pump plus CGM, and then the full hybrid closed loop on the right-hand side here. And you can see as you move from left to right, there's a reduction in the HbA1c. Before you take into account the years, they're just as a rough line I've just put on there, not a statistical line. However, if you look at each of the individual modalities of insulin delivery, they all appear to be going up. So if you look at this, you might come down here and look at your HCL, when I focus my eye on straight away and say, we're not doing as well as we were 2 years ago. How come the median H1C for the country is coming down, yet everything is going up? The reason is this is a statistical anomaly. I think it's called Simpson's anomaly. Our Ashton will tell you. Is that what has happening is that people are moving, there's a drift from here down to here. Now, in the early days, the early adopters of HCL were probably those people who were going to do quite well to start with. They were the people who wanted the technology earlier. We're now inviting or asking people up here to go onto these technologies. It's going to take a little bit longer, possibly, to get them from here to there. And so it's inevitable, probably, that you're going to see a little bit of a rise here initially. The hope is that that will plateau and start coming down again in time as we gradually move out. And that's why these have gone up. So, what I've got to say is the size of the board is the number of people. So you can see the number of people have gone up dramatically here. They've gone down dramatically here. So that's why you get this sort of anomaly, if you like. When you see this in the report, first time I saw it, that was what I honed in on and thought, people aren't going to be too happy with that. But I'll come to terms with it, and I think it's correct. This conference is about inequality, and as you know, for a number of years we've been presenting data demonstrating that there's inequality in outcomes for children with diabetes. I'm just going to show you a couple of graphs about that. This is the mean HbA1c by deprivation quintile. So that these are the most deprived children. Again, this is taken from postcode, most deprived, least deprived. And you can see there remains this difference between them, which has been pretty much the same over the years. It hasn't changed hugely. General downward trend, as the H1C has shown us, but still differences. And this is the ethnicity data, which shows a similar sort of thing to the deprivation, in that there's this downward trend. But there are differences, particularly the ones that stand out here are the black children with type 1 diabetes. There's a little bit of evidence, I think, that these are beginning to come together, some of these other ethnic groups, and I think that's encouraging to see those starting to overlap a little bit, and I'll show you some in the next slide. This is use of real-time CGM. This is the ethnic groups on the left. This is the deprivation on the right. So you can see in each group, there's been a massive increase in the use of real-time CGM. If you start over here, I think there's evidence there that those are coming together a little bit. You see there's not a huge difference now between the least and the most deprived. There's a small difference, but it's getting closer than it was down here. And over here, I think there's evidence is getting a little bit closer, apart from the black children, who I think require still some more work. And if you look at HCL, showing you something similar, that there still is this difference in deprivation in the last year, and there still is this difference, particularly among the black children. So just before I finish, just to take you back to the quarterly report, because if you ask a centre, and I'll probably ask any centre here, so do your children of ethnic minority status or those living in a tribe area do as well as those living in the other end of the spectrum? They probably say, yeah, of course they do. But the data suggests that's not the case. And this quarterly report is there to try and help you fathom that out. So these things down the bottom here relate to the differences in those groups. But if I just pull up the ethnicity and deprivation into a little bit larger, so for this centre, the centre is red, the national average is blue. So if you look at ethnicity and you look at white children, the median H1C in that centre was 57 against 57.4. And actually you think, that's great. But look at the non-white children here, 64.5 as against 60. So you're not doing quite as well as national average. But the bigger thing, if you compare your white children in your centre against the non-white, 57 to 64, that's quite a big difference. So it shows you're not doing quite so well as you might think. Or I'm not saying everyone's like this, I've picked this at random. And if you look at deprivation, it's a similar picture, isn't it? 55 as against 56 nationally, you think that's okay. But if you look at the non-white children, 64 is against 59, and the difference here, 55 to 64, nearly 10 millimoles difference. So I do urge you to look at these things down the bottom. Sometimes you have to get your brain around them a little bit, and there are other things about diabetes type and age there as well. So I'm going to conclude by a couple of summary points. So I think we have seen, again, dramatic improvements in the clinical outcomes over the last 10 years. And I always say it's approaching that seen in other leading countries. We are getting there, but they keep getting better as well. So we've got to catch them up at some point. I still don't know the answer to this question. Certainly the use of the more advanced technologies associated with the lower H1C, but the inequalities are a problem. But I think there's a little bit of evidence that might be stabilising, and I hope that will go on to be the case. So I thank all of you in the room for submitting data, because I wouldn't be standing here without you. The team at the RCPDH, they're small, but they do work really hard. Our funders, HQuick, will please keep us online. There are people who help me and help the project, who give time up to me on the project board, data set and methodology team. Thank you to all you and all the managers who sent us data, and particularly the children and families living with diabetes. Thank you.
Thank you, Justin. We've got about 5 minutes for any questions.
Yeah, no, it's the question is fun. Sorry. Bye-bye.
Which way was I going? Hey, that's good.
Thank you. Thank you very much for that. My name is Kia Ali. I'm a consultant pediatrician at Milton Keynes. I'm also the chair of the safeguarding subgroup of AIM-1. My question is, when we look at health inequalities, will NPDA consider looking at children in care, children on, say, child in need plans, etc.? Thank you.
It's wrong.
Yes and no. We are looking particularly around learning difficulties and things like ADHD. Very, very difficult to measure, of course. But there are, of course, other inequalities. We did something a few years ago, and I can't quite remember the outcomes on children living in care. It was something, one of our spotlight audits. It lends itself better to a spotlight than to a national audit. So these topics do keep coming out. So we'll take a snap of that and keep it at the back of my mind for the methodology group. But I think you're absolutely right. It is an important thing to look at. Particularly, I know Fully has been asking us about learning difficulties since ADHD. You could add on eating disorders. You can add on all sorts of things, mental health. The difficulty is how do you actually measure it? And we've been asking our epilepsy audit about how they do it. If they have a far greater number of children with learning difficulties in their audit. But it's not quite the same thing in terms of comparison. But anyway, it is under discussion.
one of the difficulties, Justin, we've talked about with the safeguarding and the looked after children is the small numbers and the identifiable nature of it on a unit report, isn't it? Which is why if we can do a spotlight, that would be amazing.
Stunned into silence. Nobody online? Oh.
Hi, Nicola Trevelyan, consultant. Thank you. As always, it's a great and really clear picture of how the data has helped us over the years. And I think my question is maybe the elephant in the room about how we collect the data and how clean the data is at unit level, because a lot of us subscribe to HICOM, to Twinkle, and as the data has become more and more complex, as we're trying to submit more and more detail and be able to try and pull out what the themes are here and what is affecting our outcomes and what is helping us most, it becomes more and more onerous for us to try and make sure that the data is really clean and it is accurately reflected what we are doing in our practice. Is there any move to try and nationalise and align a data collection thing within the NHS? Or, you know, it's a very expensive database. It's a brilliant database, but it is really complicated to use. And as each new iteration comes out, it becomes harder to sometimes find how we're submitting the data, you know, where the errors are in our report, where we know that we've done care processes, but they haven't somehow fed through to the report. I'm constantly raising tickets with HICOM to try and find out where my data has gone.
It's a very good point, and it does come up at our project board and methodology group quite often. It would be lovely if everyone had the same interface. That would be very costly to work with the 175 different centres who all have different systems, different EPRs, different this, that and the other. I'm not a great computer wizard. We are building a new platform which was going to be available in April, May, which has the ability to do that integration, although we're not doing that straight away, but it will have the ability to do that. So I think that will be the phase 2 to see how we can do that, but it's going to require quite an injection of money, of which there isn't any in the NHS. So I quite agree with you. It'd be lovely if we had a system like they do in Germany, everyone has the same interface and they could do an audit any day of the week because it's all uploaded every night into a central database. Unfortunately, we're not in that position at the moment. The new platform will have quite a few new little tricks in it integrated into it. Will give you instant feedback about your quality and completeness. So it's going to be a pretty much a good upgrade on what you get at the moment. And it's nearly ready to go. Ben.
One more question.
Oh, hello.
I just wanted to ask about, I wanted to ask about the quality improvement element. So we've collected that data and we can see, the significant different outcomes between Black children and others, and same with deprivation. And what's the next steps in terms of QI, the so what of that data, and NPDA's role in that, please?
Julian, you answer that question? I mean, to say I could stand in and say it's not really the remit of the NPDA fully, which is not. But of course, the NPDA has been involved in it because we're producing the data. Well, we could say that's our job finished, and you lot take it away and do your projects. And that's a little bit what GIRFT is about. It's trying to go around and find out where people might need help, etc. And there's always been a good integration between NPDA and those sort of processes. So they do integrate, but there also is a bit of a demarcation between doing the data and at the next stage. But if you want to answer anything different, equally, I'm just going to talk about how you put strategy into improvement anyway later. So.
Yeah, I was just going to say that's my presentation, really. Yeah, because I think that's so important, isn't it? That's probably the most important question. Is we have this amazing data, but then so what? How do we use it to improve outcomes? And I think that's where we're very fortunate that we're able to work so well together.
to use this amazing data to then drive improvements in outcomes. I actually think that there's probably more to it, in the sense that the way that NPDA and the college works with the network and with NHS England, but also with individual units in its own right, makes a massive difference. Because I think you're probably underselling yourself a little bit there, Justin, because I think conferences like this, sharing good practice, and the way you guys work with individual units and the unit level reports, that in its own right does a lot to drive improvements, because units then have the opportunity to look at their own data in detail and then start to think about what they need to do to improve outcomes. So I think, compared to many audits, because of the amazing buy-in that NPDA has been able to develop over the years, I think our audit does a huge amount in its own right. But then, of course, it's the next step of then how we use that data for things like Getting It Right First Time programme, which I'm going to talk about a little bit as well.
Yeah, I agree. I mean, the fact that we're here today talking about inequalities is this afternoon we'll have some presentations from centres where they have made a difference, and hopefully we will take those messages away and make differences in our own units. So, yeah, thank you, Fulia.
Thank you very much, Justin. So next I'd like to introduce Professor Julian Hamilton-Shield, who I've been meeting online regularly for the last 4 years, but I've never met in person. So pleased to meet you, Julian. We've been working together on the NICE weight management guideline, which was published last week, and also on the evaluation of the complications from excess weight clinics.
Thank you, Dita. People may be a bit confused because I'm doing a presentation which doesn't have any numbers in it, doesn't have any p-values, doesn't have any confidence intervals. And I should explain that this is work of lots of other people who I put on the last photo, not my work. Anyway, me and Tim Barrett decided a while ago, there was a call from the NIHR to look at outcomes related to underserved communities. And we thought it might be quite a good idea to look at type 1 diabetes and actually type 2 diabetes, and look to see if we could identify how to improve the care of various groups that I'm going to show in a minute, but Justin's already shown the deprivation and ethnicity data, to see if we could actually improve the outcomes. And we called it Improving Outcomes for Children and Young People with Diabetes from Socio-economically Deprived or Ethnic Minority Groups. In fact, the young people who worked with us decided that diversity in diabetes was a much better term. And so we're going to call it diversity in diabetes from now on. But if you can remember what we're trying to do. And it was a collaboration initially between the Children's Hospital in Bristol and the Children's Hospital in Birmingham. It's got a nice little logo now, Diversity in Diabetes, and I have to say it's funded by NIHR, Award 202358, and therefore they'll be a bit more quiet now. It's obviously me and Tim Barrett, and I'm doing this for Tim Barrett and the rest of the team. So what's the research about? It's about looking to see if we can work with diverse groups to identify the barriers and possibly the engagement tools that will allow them to get better diabetes control. And we focus on children from ethnic minority heritages who live in this country, and also those who come from the indices of multiple deprivation levels 1 and 2, which puts them in the bottom quintile of the income in the country. So this will be places, and I'm not going to say places, but places of rural communities, maybe some seaside communities. And the idea was to work with the multiple ethnicity groups and with the deprived people of white extraction to look to see how we can improve their care. And this has already been shown, and I haven't got such up-to-date slides as Justin, because we had to present this a few times and I haven't changed this, but essentially it presents the same. The people with the most deprivation, this probably has got one of those, I hate these, but these are the most deprived children and they have the worst outcomes. Everything is coming down, but probably that gap was bigger at that stage. I think it was about 2022. And here we have the children who are of black ethnicities, and they do far worse than those of white ethnicities. The rest are probably coming together again, as I say. But in point of fact, what's happening, or what we felt was happening, was that actually those from black ethnicities were diverging from the rest. And so they were doing even worse. Whilst everyone was getting better, the difference between black ethnicities and everybody else was getting worse. And we wanted to try and address that. So there's not been that much work done. There's been some work done in Europe, a little bit of work done in Europe, usually in the Scandinavian countries, a little bit of work in the USA, mainly in Minnesota, where there's a very large Somali population, but not that much across the world. When we looked at the systematic reviews, we wanted to understand what young people had to say, what their parents had to say. And in addition to the systematic reviews and ethnographic reviews, which are looking at people's experience and actually the written experiences they have, we wanted to develop and co-design an intervention that would work for them rather than working for the clinics. And that's kind of an important concept, really. It's doing things for people with people's actual engagement and co-design. So the way the study worked was that we did these systematic and ethnographic reviews, which is basically taking the quantitative evidence and the qualitative evidence and synthesizing it, and then identifying key themes in the ethnography ones and key outcomes in the sort of quantitative ones. There wasn't much quantitative for me. I had to listen to what other people said, which is always difficult for me, but nevertheless. And then we were going to do a lot of qualitative interviews with young people and their families, and also, when we distilled that evidence, actually have a co-design group so that we came up with ideas. It went to the young person's advisory group, and that young person's advisory group was very reflective of the population we were dealing with, and got them to tell us, well, that's not going to work, or that's going to work, we can't have that idea, or we really hate that idea. We thought we probably ought to ask healthcare professionals as well, and we'll talk about that in a minute. And once we'd designed the trial, we're now in the feasibility area, so we're doing a feasibility study in 2 sites. I don't know if anyone's here from Leicester or Nottingham, but those are the 2 sites, and we've just got ethics approval last week. And then eventually, refining that from what we find in that, we will then deploy the intervention in a cluster randomized trial in 30 centres with an internal pilot of 10 centres. So you do 10 centres first, see how it's going, make sure NIHR want to fund the whole thing. And if that's the case, then it will go out to 30 centres across the country, which either have significant levels of deprivation or significant numbers of different heritage groups that might benefit from this study. The systematic reviews and ethnographic reviews have already been published, and I'll just show them for you here. And you can look to see them, and they're in Diabetic Medicine and one in a Journal of Health Inequalities. And they were quite helpful in identifying the questions and themes that we were going to put into the interviews with our young people. I don't think there was anything revelatory, and in fact some of these studies relate both to adults and children, although for the ethnographic ones, the qualitative ones, we were only looking at children. There wasn't that much evidence. There was a little bit from the UK, there was a little bit more from Scandinavia. We did look at the American data, but the American data is very difficult because their healthcare system's so different to ours that it becomes really difficult and intractable to try and utilize some of that evidence into a healthcare system which is completely different. But Scandinavia has a healthcare system similar to ours. It's rather more effective than ours, but that's not my fault. But we did use the data mainly from Europe. And then you've got to understand what we did next is basically you have to take all the evidence you get, and then you have to apply it to something called the COM-B framework. Now, I'm really out of my depth here, But basically what you're looking at is the capability of people to change, the opportunity for those people to change, and what's motivating them to change. And from that, you can actually identify which sorts of interventions you're going to do to enable people to enact effectively what's a behavioural change. I mean, we all give the same insulin, or more or less. We try to get people on pumps, more or less. We try to put everyone on CGMS, more or less. That's what we do. What actually the problem and the issues are is what people do with the stuff we provide them with, and how we can get them to feel motivated to use them to the best of their ability. And that's where the COM-B comes in. So what did we do? We took the children from the Children's Hospital in Bristol and the Children's Hospital in Birmingham. And you may think, because people think this, that Bristol is a very white city, and it is kind of quite a white city. But if you actually look at the number of the children in primary school, about 31% of our children now come from other Somali or South Asian extraction. So actually, the Children's Hospital, which deals with Central Bristol, actually has a significant, I wouldn't say majority, but a significant group who actually come from different ethnicities. So it allows us to do this study. And what we did is we recruited patients who we thought were either in IMD scores 1 and 2, because we collect that data from their postcodes, or who were from different ethnicities. And we asked them, would you mind talking to some researchers? And if they said yes, then we said, could we have our contact details? And the contact details we then gave to the researchers, who obviously work in our university but don't work in the actual clinics. And then the researchers contact them to do some interviews. And when you do these sorts of interventions, when you do these sorts of interviews, you have to try and have a theory behind it in order to try and identify what you're trying to do and what you're trying to say. And so the theory behind what we were doing is to apply the burden of treatment theory to see if that was applicable to this group. And again, not really my subject, but however, I think I've distilled in my brain what effectively it is. If you've got cancer, so let's say some children with cancer, the doctors will tell you your child's going to go on to UCAL, whatever it is now, 15, 16, 17, I have no idea, it's a long time since I did it. But you will go into that and we will give you these treatments. And you will have these treatments and that's the treatment. And you don't have to think about it much. It may not be very nice, but we're telling you what treatment you have. The burden of treatment theory suggests that if you furnish a drug like insulin and some insulin pumps, and you say to people, go on, go away, come back every 3 months and tell us how you're getting on, you're plonking a huge amount of the treatment adherence and the effort of treatment onto the child and their family. So the burden is not our burden, which it is in oncology, for instance, because we're making up all the treatments. The burden for most of the treatment lies with the family and the child. So therefore, situations which are going to get in the way of them being able to adhere to that, which have multiple different, socio-economic, familial, personal, bullying at school, as many as you want to think about, are all going to impact upon the person's and that family's ability to provide optimal care. And that's kind of the essentials behind the burden of treatment theory. And as you're hopefully not all psychologists, you're all not going to come up to me afterwards and go, what are you on about? That's nothing to do with the burden of treatment theory. So who did we actually interview? We had quite a decent spread of patients. We had mostly, the people who wanted to speak to us mainly sort of the adolescent group or late primary school, early secondary school. We had a lot of Black and Black African population, quite a lot from Bristol, some from Birmingham. We had more South Asian population from Birmingham, and we were able to get some people from white heritage who came from the IMD scores 1 and 2. I would say quite a significant number of those came from a seaside town near Bristol called Weston-super-Mare, which does have a significant amount of deprivation if everyone's ever been to Weston. And we did interviews with sometimes just with the children alone, sometimes with the parents alone, and most of it was the parents and the children. And in total, there were 43 interviews and 69 participants, all from those really quite hard to reach groups. So actually, we were quite pleased with that. We did aim to get to 80, but it was okay because people don't like this term anymore. We got data saturation, which meant that no new themes were coming up by the end of the time we'd done the interviews. And from that, we did some thematic analysis. Well, I didn't do the thematic analysis. My qualitative researchers did. And they were looking at basically different groups. I'll leave this up for a second. There aren't going to be lots of quotes, because if you put lots of quotes, people spend all their time reading them. But there were internal barriers, there were relational. The internal barriers are your self-efficacy, your motivation to change, or your motivation to keep going. The relational barriers were relationships with family, relationships with people at school, all these things that you know about, because I'm sure you've heard about in your clinics. I'm not really getting on at school. I've lost all my friends. In fact, I've been excluded. All these sorts of things are getting in the way. And then probably more sobering were the clinical barriers, because we had a lot of young people tell the interviewers exactly what they thought of us, which was vaguely interesting, to say the least. And quite a lot of what came out, or the interpretation of what came out, was that perhaps we're a little bit judgmental and we don't understand the situation these families and these children are living in and how complex their lives are. And we only talk about HbA1c. And the other thing is, it probably is me, the one below, because he's talking about basal rates, this rate, glycated. I don't know what he's on about. He's just talking gibberish to me, and I just feel deflated. So we learn quite a lot about how we talk to patients and how sometimes what we're trying to convey and what other people, what they want to talk about and what they're interested in are probably not quite the same. Anyway, working with those different groups, we then applied it to the sort of burden of treatment type theory, and we looked to see which aspects the agency of the young person to make changes within themselves and what affects their ability to adhere to giving boluses, eating, doing carbohydrate counting properly, and all the things that we know are quite difficult for everyone. And then looking at their relational networks. And those can have quite significant effects. I mean, we all know this. I mean, I can just think about some of the patients I've seen over the last month where they're not particularly getting on very well with their families. But it's quite interesting because this all has to be looked through the prism of different cultural relationships as well. And so it's not just a middle-class white family where you don't get on with your dad because he never comes home because he's always at work in outpatients. It's also the other relationships that sometimes the father's probably not around. They're not around very much, and they have no real control. That the fathers often don't really know much about anything other than what food's on their plate. They don't really get They don't really get involved in the cooking. They're often working very long hours. They're often working at night. They're not there in the morning when the child's getting up to go to school. And all these sorts of aspects that not always applies to not all families. And then there's some level of the community and the control of the service. So how much do the young people and their families have control over the service that we provide? Because we provide a service and they can opt into things we offer, but they can't opt into things we're not offering. If we're not offering, they're not going to say, well, why don't you have a peer group meeting every month? Because they don't have the opportunity. They don't probably even know what that is. And unless you offer it to them, they've got very little chance of changing that. And then over here, the opportunity is what are we actually offering them? What opportunities are we offering them to make better decisions, be more motivated to make those decisions? And also remember, I have to keep saying this because I keep forgetting, remember it's the context of what's important in their lives, not what's important in my clinic or my outcomes and where I appear on the NPDA. So we took all that together and then we applied it. We looked to see if the burden of treatment was able to explain everything. And I'm probably not quite that surprised. In fact, it helps, but it doesn't really explain the issues we have with groups from different cultures and different ethnicities and those who are from very poor backgrounds. And it's probably not that surprising because now we start thinking about things like epistemic injustice. Epistemic injustice basically is another theory that suggests that the way society is built and the way we furnish our care, I mean, it can apply to other things as well, but in the context of healthcare, is often related to biases, unconscious biases, and time and everything else that doesn't allow the people who you're trying to care for the opportunity to explain their illness in the context of their life and their culture. And thereby, you don't do the best for them simply because you haven't accommodated their different cultural mores or their different financial mores. It's quite an interesting one, and we're going to take that further, and we're going to write some papers about that. But certainly the burden of theory was a nice idea because it kind of makes, but I think that really applies to all people living with type 1 diabetes and probably didn't explain the specific issues that different cultures and different heritages have, and those who are very poor backgrounds. So it's a nice idea, and anyway, you have to have a theory. If you find the theory doesn't really apply, that's fine. The MRC doesn't mind, the NIHR don't mind. So we thought we probably ought to ask a few people in healthcare professions what they thought as well. And so we had 2 online modified Delphi consultations where we recruited people from 4 regions, so like the Southwest Diabetes Regional Network, and we also had the Wessex, and I think we had the East of England, and we might have had London, and if I've forgotten someone, I do apologise. But we had 4 different regions, and we asked healthcare professionals from across the spectrum, and they certainly weren't all doctors. We asked them to identify what promising strategies they thought they might have in work package 1. And then we took that back to our young persons advisory group and said, what do you think of these ideas? And would you like to say something else? And then we came up with what the interviews said and what our qualitative data said. We'd already done the qualitative and quantitative data, but not all the interviews. And we distilled all that. And we sent it back to the Delphi saying, this is what we actually think the young people want. What do you think about that? So in survey 1, this is probably not that surprising. Who's the best people to target if you're going to target an intervention for these different groups you've already been talking about? Well, target those with a high HbA1c. There's nothing wrong with that. And they thought that you could have more staff outside clinics and more community orientated key workers and stuff. Another good idea. Person-centered solutions. I'm not sure that's telling me anything other than you ought to try and deal with the person rather than the disease. Some people suggested acceptance. Well, I think this is acceptance and commitment therapy could be quite useful. In fact, it probably could be quite useful for people. If somebody doesn't know, acceptance and commitment theory is a tertiary form of cognitive behavioural therapy. I'm sure you all knew that anyway, but it was new to me. And then there was things about you could try and give people laptops, you could try and give people mobile phones and things like that if they don't have the money, so they can access that technology, which again seems entirely reasonable, and it's something we certainly do in Bristol. And then they talked about clinical, well, that's actually what came. And then we said, well, okay, thank you very much. And then we went back and did talk to the young people again. And they said, well, actually, we quite like some peer support programs. So we said, how can we get those peer support programs? And then we had someone at Diabetes UK, it was Charlotte Austin at the time, who's now left Diabetes UK, but she was very, very helpful. And she said, well, actually, funnily enough, we've just set up this this peer support groups across some of the areas of the UK, but we hope to do it in the whole of England anyway. do you think we could dovetail with that? And I said, we thought that was absolutely a fantastic idea because we don't have to pay for it. It doesn't have to come out of the research or excess treatment costs. So we said, thank you very much. We went back to the survey too, and they all thought that was a wonderful idea too. The second one the young people came up with was health and well-being coaches, which is something I haven't really come across before, but they use it in type 2 diabetes quite a lot. And the idea is that you go to a health coach or somebody who basically talks about how you can, they're a support mechanism to allow you to make those changes. So in type 2 diabetes, they're often talking about doing lots of exercise, doing more exercise, eating more healthily, giving up fags, taking your blood pressure tablets, and how you're going to go about doing it. Everyone thought a family support worker, the young people thought family support workers or youth workers were very good, but the healthcare professionals felt they must be internal to the team. They could not be outside the diabetes team, again, which seems fine. Clinic ethos, I mean, this is happening all whilst the poverty proofing and bridge the gap work was already being done, but it came out contemporaneously. So we weren't nicking the ideas, they just happened to come at the same time. And the other one, the healthcare professionals said, additional clinic sessions, no, thank you very much. We really can't do that. We've got enough on our plate already, which I didn't think was that unacceptable, very reasonable indeed. But, it's interesting that the young people felt that might be helpful. The families felt that might be helpful, but that's simply not going to happen. So when you've done all that, what's the next thing you do? Well, you have to see if whatever intervention you've designed fits the appease criteria, which kind of makes sense. And the appease criteria, it's acceptable to the patients, it's practical to deliver. One of the important things is it's effective, and you have to show it's effective. And I haven't said this, but actually in the cluster randomized controlled trial, we have set that those clinics that get the intervention compared to the clinics that don't have to improve their glycated hemoglobin by 8 millimoles per mole more than those who don't get the cluster. So you have to show some clinical effect. We thought that was a minimum amount that would be effective. It has to be affordable, which is an interesting idea. And you have to make sure that you don't have any what's called spillover effects. It's like the side effects of drugs that we give. Don't make sure you don't actually make things worse for people. And it has to be fair in the way it's delivered. So, when you've got all that together, you've got all the questionnaires and the interviews with the young people. You apply the COM-B, which I haven't gone through, but I'm trying to read the paper on the train, and I still don't really understand it. But anyway, you map it all to this, and then we had the focus groups with the Young Persons Advisory Group, children and young people with diabetes, and some families. These are not numbers of people, 1, 2, it's a number of meetings we had. There were about 6 to 8 in each group. We had 2 sets of healthcare professional surveys. We applied the appease criteria, and we thought the intervention elements could be peer support, life coaching, family support worker, and changing the clinic ethos. So, on the individual level, those people in the intervention, those young people recruited to the intervention and their families, will have a life coach who'll do about 8, well, in fact, actually, I've got another slide just after which it tells you a bit more detail in more big writing, so you might be able to read it. At the community level, we're going for a diabetes community support worker, which some of you have already, but we certainly don't in Bristol, and quite a lot of other places don't as well. And then the clinic level, this is more difficult. We got to check the additional diabetes clinics. We said no, so don't worry about that. This is what my qualitative researchers thought we might be able to do, but I'm not sure we can. And then focus on the nature of the clinic, the ethos of the clinic, and the attitudes people have. And that's already, to a greater or lesser extent, being dealt with by the poverty proofing courses that lots of people are going to. But we're also going to provide another, it's not a course, but a session to each clinic about what our findings were and what we feel young people want, or what they told us they wanted and what the families wanted. So there'll be some further educational things. So the peer support group will be delivered by Diabetes UK, and the two, I managed to work out a way of plotting little crosses onto things, but I'll tell you, Leicester and Nottingham are doing the pilot study, and they'll have access. They will recruit the key worker who's going to work with the young people, is going to arrange with Diabetes UK for them to go, probably as a group, to a peer session where they can talk to other people with type 1 diabetes. And they do lots of things like taking them out for days to, I don't know, one of those park type things where people jump around and stuff like that. And then I'm sorry, I can't remember what they called, centre parks and things like that. And then a life coach, we're going to teach the key worker how to do a life coaching course. In fact, I'm paying for the first two, and I'll tell you a little bit about that later on. And that life coaching is there to be a support to the person themselves. So each individual young person will have about 8 to 10 sessions if they want. If they only want one, they can have one. If they want 8, they can have 8. If they want 4, they can have 4. They can't have more than 10. And that is to support the person in terms of the extraneous things that get in the way of their diabetes management, offering them further stuff. And those just talks through I've got lots of pictures of the diabetes life support. And we've arranged for this EHCAP, which is actually run by a GP who did lots of work on motivational interviewing, and she set up a teaching service that these healthcare workers can go on, and they get a qualification. I think it's a sort of level 3 something. But it means that they've actually got some qualifications at the end, which means that they basically improve their job, their CV and their portfolio, which allows them to be a life coach for children. And in fact, we picked this group because they specified they did life coaching for young people as well. The community health worker is very much, as many of you will already know, but it'd be nice if we had it in Bristol, although Bristol's obviously not going to be one of the teams. And they'll work with the parents in the community, with schools and stuff, trying to enhance the support the young people get in the community. And then we come to the next one, which is focusing on the ethos of the clinic. And I'll just leave that up for a second because I think it's kind of important. So be positive, be judgment-free, and make a constructive space for the young person. Sometimes it's brilliant doing clinics, and other times by the end of it, you've had a difficult clinic and you're seeing your 10th patient, and they've got a glycated hemoglobin of 86, and you're seeing them every 4 weeks to try and support them. And you think, I'm not sure what I'm meant to say now, but you're not really doing very well. But you've got to try and find a way of saying, this is what you've improved, and you've done this, and thank you for actually coming along to the clinic, and thank you for giving me 1 day of your CGM out of 120 or whatever. But you've got to find the positives. I'm really determined to find the positives. And we also have to be more aware that different ethnicities suffer from different constraints, and being very poor does put a huge burden coming to clinic regularly, and some of the things we ask them to do become quite difficult. This additional clinics group sessions, I don't think it's going to happen, but I do think what might happen is some of the peer review types, peer support type stuff from Diabetes UK can do some of that stuff about increasing technology awareness and stuff. I don't know about everyone else, but I feel that we've kind of addressed this already in Bristol, as we had a special paediatric diabetes specialist nurse for a year who basically went around teaching all the people who we thought were underserved about access to technology. And we've upped our access to technology more or less to the same as our middle class white population. So we're quite proud of that. That was Toby Candler and nothing to do with me. So the overall aim is to determine the feasibility of providing complex care. That's where we are at the moment. To demonstrate the site's going to appoint and train staff, which we're doing, that we recruit 18 people per site. which is that's what we're offering for each site, that the participants and their guardians can engage with the intervention. You're going to say, what does that mean? I'll tell you in a minute. And we with the feasibility study, we can actually refine it prior to going to the cluster randomized trial. So which bits they like, which bits don't they like. And then basically, that says the same. So what's the criteria? So it's pragmatic, this little bit, and that's my attempt at Nottingham, that's my attempt at Leicester, but actually that doesn't look too bad. And the eligibility, if you're white ethnicity, you have to come from an IMD 1 or 2 school. And what we did find is that actually IMD 1 and 2 schools don't necessarily mean you're poor. If you live in an IMD 1 or 2 school, that happens quite a lot in Bristol. The middle class move into an area that looks quite attractive, take over the nice houses, but they live in an IMD school 1 because it's not done every year. So also they had to be eligible for free school meals. And that's how that's kind of how we're going to equate that to poverty. And then anyone from a UK minority ethnicity can be recruited. I've got to do that one. Sorry, I'm pressing the wrong button now. And so we've got criteria for success that we can appoint. We've done that. Each centre can recruit the 18, and at least 80% will still be engaged in the intervention 6 months after convent. Now, that's kind of important because you may not want to do 10 coaching sessions. You may want to do 1 or 2, but you've got to still be engaged at the end. You've got to tell people what you think about it. And they receive the relevant components of the package that they want, not necessarily completing it. And then we'll do some further interviews with healthcare professionals providing it and with the people who have actually been through this through virtual semi-structured interviews to refine the process. And this, I think, is my last slide. And then we'll move on to work package 4, which is a cluster randomized trial starting in 10 centres, eventually ending up with 30. And that's it, except for to say these, I'm not going to say everyone, some people, funnily enough, don't like their photographs being shown, because I asked them for photographs, they said no. So I said, can I put your name? They went, yes. So this is a Bristol team, this is a Birmingham team, this is our PPI group, Diabetes UK, and Kerry Beavers-Leeson, who does a lot of work with rare and marginalised communities. Thank you very much. I hope that made some sense.
Thank you very much, Julian. I think one thing that really struck out for me there is we're not very good at doing different things. We're very good at doing the same thing repeatedly, even though we know it's not working. So in many people's high HbA1c policies will just be keep doing the same thing more often, and it still doesn't work. When can we expect the final analysis? When is your expected completion date?
Right. Unfortunately, due to all the ethical constraints we have and going through various different things, we're behind time. So the feasibility study we need to report in the middle of this year, and then we'll get the go-ahead to start the feasibility study or not. So I would hope it would start sometime, the cluster randomized controlled trial, probably about September 2025, maybe going up, being realistic, maybe the beginning of 2026, which is a year behind. So,
looking forward to seeing the results of that. And I think we've got time for one question, and then it's coffee.
Hi.
One at the back
really
there, and then just
shout at me as much as you like.
Does it be?
Hi, thank you very much for the lovely presentation. Can I ask you to put the HbA1c slides up? Just it helps me to express myself. You know, the one with various groups.
Yeah, it's an old one. Justin had
it's the second or the third, probably it was.
That one?
That's the one. Yeah, that's the one. I mean, looking at that, whatever we do to support any group of our patients depend on the recipient and how much motivation we can create in them. Looking at these slides, actually the motivation is almost equal in any group. They are improving from whatever, if you start from 75 down to 65 or from 70 down to 60. So both groups are tremendously motivating themselves in response to our support in order to provide better outcome and better control of their diabetes. So where do you think we could, I mean, I don't know, I can't see, I think the gap is probably a little bit wider at the bottom or maybe equal.
I would argue this gap is widening, and I don't know what Justin feels. The gap between the black population and everybody else, which I do think is still quite significant.
It is.
You could say, actually, there was a paper came out from Birmingham and various places saying this may be, to a degree, insoluble because they may actually have greater glycated hemoglobins due to physiological reasons, but not to this level. So the argument goes, if one group are not doing as well as everybody else, doing the same thing, what things can you put in to that group that might improve their outcome and bring them to the rest?
Exactly.
And so we're just wondering whether the peer support may be, but I think the life coaching bit may just give that group of people, and if we just say the black population of the UK, might give them the extra support they need so that they actually come down closer to that. I don't know, it may not work, but if the white population is doing fine anyway, and we're doing quite well, we're not doing as well as some European countries, perhaps we ought to go to European countries and looking, but I would be very interested if the average glycated hemoglobin for all those other countries you've shown, Justin, even the ones doing really well, I suspect they still have that disparity in outcome. So universally doing the same thing I don't think helps. So the idea behind, I'm very taken with the life coach bit, because I don't think we've done that before. And the idea would be that it would enable those young people who, for whatever reason, are struggling to have somebody else to talk to who's actually got a positive reinforcing impact on them, that may allow them to make more adjustments than, because the white population aren't going to get it unless they're very poor. And so I think it's just, you might just argue it's the extra input. Why don't you just give them extra clinics? Well, I think it's probably better than giving them extra clinics, because I don't think they like coming to clinic anyway, and it's quite costly for them, whereas I think the life coach can visit their house or arrange to meet them in the school and everything like that, or wherever they want, to give them that extra reinforcement. So I think it's trying to make that grey come down here.
A little bit more.
And I think that's why. I agree, everything's improving, but if it's not improving as much in that group as everyone else, why? And it may well be that we're not giving them the necessary tools in our clinic that they can get from a life coach. That's what I think we're testing. On the other hand, it may be impossible, and it may be that physiologically they do have a slightly higher glycated hemoglobin, but I don't think it explains that quite significant difference.
I mean, one would ask, they are improving, but not at a speedier way than the rest of the group in order to catch up.
Yeah, and I think, and I'll shut up after this, but even after you take access to insulin pumps, closed loop systems, and everything else, I still don't think our black population in Bristol, half of my clinic comes from the Somali extraction. I don't think they do as well as the other other clinics' white population on the same best technology.
Thank you very much.
Thank you.
Thank you. I think we'll close for coffee, and if everybody could aim to be back in this room a few minutes before 12 so that we can start on time. So please grab your coffees and then come back in. Thank you.
That's right.
How are you?